Thank you very much. And I would like to welcome the faculty, panelists, and the audience to this webinar, which is titled as Advances and Insights in Intravenous Fluid Therapy, which is absolutely important component of our care of patients, either in the operating rooms or critical care units or in the emergency units. Which fluid to give and how fast to give and when to give are the questions which always bother our minds. But I think at the end of the seminar, we'll be able to have clear-cut answers to these. And as you may be aware, Indian College of Anesthesiologists, which was started in 2008 as an academic offshoot of Indian Society of Anesthesiologists, now is running independent academic events. And the one of the hallmark of Indian College of Anesthesiologists is its webinars, which are conducted on a weekly basis. Every Wednesday, 7 to 9 p.m. is allocated to the ICA webinars, which have become very popular and well attended. And today we are going to discuss about intravenous fluid therapy. For this, I have faculty drawn from anesthesia, intensive care, and emergency background. For moderating this webinar, I have Dr. Kodandaram, yes, from Akash Medical College, HOD of Anesthesia in Akash Medical College, Bangalore. Dr. Manjunath HG, who is the Dean and Director of Chamaraj Institute of Medical Sciences. Dr. Guruprasad, a well-known intensive care specialist from North Karnataka. Dr. Sharada Suresh, again a multifaceted personality, working at the Narayana Institute of Medical Sciences in Bangalore, and myself. I am the academic director at the Narayana Institute of Cardiac Sciences. And we have faculty from Moradabad, and I am very happy and delighted to see that young people from Moradabad have come forward to present this seminar. I request Mukesh, Kumar, Prasad to introduce his colleagues who will be participating in the seminar and then start the first lecture. Thank you so much. Stay back till the end to have a good discussion at the end.
Good evening, everyone. Thank you, sir. First of all, I would like to thank Muralidhar, sir, for inviting us in this academic session. And from our side, we have 4 participants, including me. I am Dr. Mukesh Prasad, Professor and HOD, Department of Anesthesia, Tirthankar Mahavir Medical College, Moradabad. And together with me, we have Dr. Payal Jain, Professor Anesthesia. And with us is Dr. Shambhavi. She is looking after critical care department here in Tirthankar Mahavir Medical College. And again, we have Dr. Vinamra, who is looking after emergency medicine in the same medical college. So to begin with, I will start the session with my lecture and followed by Dr. Payal Jain, then Dr. Shambhavi Chauhan, and then followed by Dr. Vinamra. So shall we begin, sir? Shall we start, sir?
Yeah. Please start.
Okay. So I am sharing my screen.
Yes.
I think my screen is visible.
Yes, it is visible.
Yes, sir. Okay. So today I will be talking about the physiology of intravenous fluids. So now, good evening, everyone. Intravenous fluids. These are my disclosures. To begin with, coming to introduction, Now, intravenous fluids are an essential component of modern medical care and playing a crucial role in maintaining hemodynamic stability, restoring fluid balance, and correcting electrolyte disturbances. It is guided by 4Ds, that is, it acts like a drug in proper dose for definite duration and needs de-escalation too. Now, to understand the physiology of IV fluids, we must beforehand need to know the basics of total body water and how it is distributed. So as a rule of thumb, the total body water can be estimated as 50% of the total body weight. And majority of it is in the muscle mass and in adipose tissues. Now, the 60% of fluid that is in our body, it consists of 2/3 is consisting of your intracellular fluid and 1/3 is your extracellular fluid, out of which 80% is interstitial fluid and 20% is plasma. The various electrolytes that is distributed in extracellular and intracellular are, in extracellular fluid, we have cations, that is sodium, that is predominant there, and cation that is predominant in intracellular fluid is their potassium. Now, how to classify the fluids? So based on the composition, it is classified as crystalloid, colloid, and whole blood and blood products. And based on osmolality, it is classified as isotonic, hypotonic, and hypertonic. And based on the buffer and electrolytes, it is classified as balanced crystalloids and multiple electrolyte solutions like isolate G, P, and M. So how these are different? The isolate, it is based on the osmolality. So isotonic fluid has the osmolality in between 270 and 310, and hypotonic solution has less than 270 milliosmol per liter. And whereas hypertonic solution has osmolality of more than 310. So the examples of isotonic are 0.9% NaCl, Ringer's lactate, plasma light, and hypotonic solution is 0.45 NaCl, and 3% NaCl falls in category of hypertonic solution. Now, how they behave? Suppose if you are adding hypotonic fluid, we are infusing IV hypotonic saline 0.4% in a body, then how it is going to behave? It will increase the ECA volume. So since this is a hypotonic saline, it will decrease the osmolarity. And so where is the flow? The flow will shift to intracellular fluid. So fluid shift from extracellular to intracellular fluid will be there. So there will be increase in ICA volume and there will be decrease in ICA osmolarity. So what will happen to hematocrit? There will be no change. Why? Because there is increase in ECF volume. Simultaneously, there is swelling of the RBC. So there will be no increase in hematocrit. Since the volume has increased, so plasma protein will decrease. The concentration will decrease rather. There will decrease in arterial blood pressure as volume in extracellular fluid has decreased. Now, when we add isotonic fluid, what will happen? There will be no change actually because the osmolarity is same. So there will be increase in the volume, that is isotonic volume expansion. And there will be decrease in the hematocrit because it will be diluted now. And plasma protein also, the concentration is going to decrease and there will be increase in blood pressure as volume in ECF will increase. Now, what will happen if we add hypertonic fluid? Suppose 3% saline we have added, then the osmolarity of the extracellular fluid that will increase. So what will happen? There will be expansion of ECF fluid and there will be decrease in ICA volume because now the volume has shifted to your ECF side. And there will be, since the volume of the ICF has decreased, so there will be increase in osmolarity. So this condition is the hyperosmotic volume expansion. So what will happen to your hematocrit? It will decrease. Why? Because the RBC now it has shrunk and due to hyperosmolar fluid in the ECF and simultaneously there is increase in ECF. Again, the plasma protein that the concentration will decrease because volume has increased and there will increase in arterial blood pressure as volume in extracellular fluid or blood vessel has increased. Now that I've talked about crystalloids, coming to colloids, like albumin, hydroxyethyl stars, it contains large molecules that remain in the intravascular space longer than the crystalloids and provide effective plasma volume expansion with less total volume. However, there is a risk of anaphylaxis and coagulopathy and chances of kidney injury also there. This is a very beautiful pictorial representation. Here, when we give 1 liter of colloid or RL or plasma light or normal saline, what will happen? So most of the colloid that remains in the plasma, but in case of ringer lactate, plasma light or normal saline, only hardly it is 200 ml that is inside the plasma. Rest of them are in the interstitial fluid. While in case of dextrose water, most of them are inside the interstitial fluid and intracellular fluids. Now coming to Starling's principle, in 1896, Starling, a physiologist from Britain, what he has suggested is that there is transvascular exchange depends on the balance between hydrostatic and oncotic pressure. So at the arteriolar end, what happens is, arterial end of capillaries, what happens is that there is increase in hydrostatic forces, which pushes the fluid outside into the interstitial space, whereas at the venular end, the oncotic process pull the fluid inside the veins. So this was the hypothesis, or this was the thing that he has suggested. This was the theory that he had suggested. But in 2004, Adamson and colleagues showed that the effect of the interstitial pressure on transvascular fluid exchange is very less. And this was confirmed by many other studies. So what is the current concept? So what is the problem actually? The classical model does not fully explain the fluid movement, especially in conditions like in sepsis, shock, or edema. So according to current understanding, there is a presence of endothelial glycocalyx, a slime-like, a gel-like carbohydrate-rich layer, which was coating inside the vascular lumen. This is the electron microscopic image of the same. Now, how it is formed? What are the structures? It is basically formed by the proteoglycans, glycoproteins, and glycosaminoglycans. So the proteoglycans are basically the center, and the glycoproteins and glycosaminoglycans are attached to it. There are also some fixed part and some are dynamic parts. The fixed parts are glycoproteins, glycans, and syndicans, whereas the dynamic parts are the hyaluron and the plasmin proteins. So this is about the structure of the glycocalyx. Now, coming to this, here we have shown, this is pictorial representation where you have seen the lumen along with the glycocalyx and interstitial space. So, initially, it was thought that albumin enters into the endothelium by endocytosis. Instead, the revised concept says that albumin tend to be absorbed on surface of the glycocalyx, producing a osmotic process called glycocalyx osmotic pressure, this one, which determines the movement of fluid into the venules. And 60% of the colloid osmotic pressure is determined by this albumin. Small space just below the glycocalyx called the subglycocalyx space, and there is a osmotic gradient that exists between glycocalyx and subglycocalyx space. This gradient is important to maintain the vascular integrity and movement of the fluid. So current understanding is, in revised Starling principle is, colloid osmotic pressure minus glycocalyx oncotic pressure. Okay. So which earlier used to be colloid oncotic pressure minus the interstitial oncotic pressure. So as you can see in this picture, the movement of fluid depends on the glycocalyx oncotic pressure, and when it is not happening, a venular at the venular end, because this pressure is very low, this pressure is very low. So at the end, the lymphatic system is responsible for the movement of this lymphatic system is responsible for the movement of the fluids. This is to summarize the things that I've already spoken. Now, coming to the functional importance of glycocalyx. So what happens, suppose if there is some inflammation or infection, then the leukocytes are activated and there is a release of free radicals, pro-inflammatory markers, which lead to activation of FRNase, hyaluronidase, metalloproteinases, and that what it does is that it leads to endothelial glycocalyx degradation. And it is degraded into the short heparin sulfate chains, chondroitin sulfate fragments, and low molecular weight hyaluron fragments. So what actually happens is it leads to disturbed flow, albumin extravasation, increase in permeability, and increased leukocyte infiltration. And these short fragments, they get accumulated even in brain and can cause cognitive dysfunction. Now, the consequences of disrupted glycocalyx, I have already spoken. These are some of the biomarkers like syndican, heparin sulfate, hyaluronidase, and CD44. These are used as biomarkers for EG settings. This will be discussed in detail by Dr. Vinamra. Sorry. Now, what is the impact? What is the impact of fluid therapy on the glycocalyx? So, fluids that help preserve the glycocalyx. In many studies, they have found, like in SMART trials or TD trials, they have found that the balanced electrolytes are less damaging as compared to 0.9% saline. And it maintains the endothelial function better. It preserves it better. And albumin, it binds to the glycocalyx, stabilizing it, and it decreases the enzymatic degradation. And simultaneously slow and controlled fluid administration, it avoids excessive shearing stress, prevents enzymatic glycocalyx breakdown, and prevents capillary hyperfiltration and interstitial edema. And coming to the fluids and practices that damage the glycocalyx, what are those? Again, 0.9% normal saline. It can cause hyperchloremia, leading to acidosis and increased risk of AKI, and mortality is also increased in these patients. Now, when we do excessive fluid administration, what will happen? It causes a shear stress and activation of these metalloproteinases and other factors which degrade the glycocalyx, and again capillary overfilling increases hydrostatic pressure and promote interstitial edema. Synthetic colloids, especially with high molecular weight, they also disrupt the glycocalyx and leads to AKI and coagulopathy. The inflammatory status, these I have already discussed in the previous slides. Now, how to select an ideal fluid? Is there a way? Till now, I don't think there is a concrete evidence or concrete statement that can be made to select an ideal fluid. Still, we'll try. Can SID help in making a choice? Let's see. So, a strong ion difference is the difference between fully dissociated cations and anions. So, normal SID is around 40 milliequivalent per liter, and SID is directly proportional to pH. So, if the SID is less than 40, then pH will be low, and it will cause acidosis. And if SID is more than 40, it will cause alkalosis. So, the ideal IV fluid should match the physiological SID and maintain the acid-base homeostasis, which I think is, at least as of now, no fluid is maintaining that physiological SID. Now, coming to IV fluid composition with SID, here you can see the strong ion difference of the sodium chloride. It is 0. So, since SID is 0, it is less than 40. So, whenever we administer sodium chloride, then chances there are the acidosis is going to happen. Hyperchloremic acidosis is there with infusion of sodium chloride. So, and now coming to this plasma light, you see the SID. SID is 47. This is more than 40. So, chances of alkalosis is there. But still, this is much better than what we are getting from normal saline. And one of the most rampantly used is your Ringer lactate. So, SID you can see is 28. So, it falls in the acidotic zone, but still it is better than sodium chloride. Now, common clinical scenarios and IV fluids of choice. This is just, we are trying to figure out if you can use the best fluid of choice in these cases. Like in sepsis, trauma, and large volume resuscitation, we prefer to use plasma light, which has a SID of around 50 and ringer lactates. And we avoid 0.9% NaCl. In vomiting and metabolic acid alkalosis conditions, we prefer to use 0.9% sodium chloride. And in hemorrhagic shock, we prefer to use plasma lights and ringer lactates. In diabetic ketoacidosis, initially we start with sodium chloride, but simultaneously we switch to plasma light because chances of acidosis is always there. In major surgeries, what happens is, still the choice is your balanced crystalloids like ringer lactate, plasma lights. Now, coming to Frank-Starling law, what it says is the Frank-Starling law of the heart describes the relationship between ventricular preload, end diastolic, that is end diastolic volume, and stroke volume, that is cardiac output. So what happens is, whenever you give IV fluid, there is increase in intravascular volume, which lead to increase in venous return, which leads to increase in left venous ventricle filling pressure or preload, which increases the end diastolic volume and end diastolic length. So stronger the contraction and stronger the stroke volume, and hence increase in the cardiac output. So stroke volume is proportional to end diastolic volume and end diastolic length. Just one second. Now, here I have shown the Frank-Starling curve. So here stroke volume is plotted against LVEDP. The blue one is the normal Frank-Starling curve, where you can see this ascending limb of the curve, which is preload dependent or fluid responsive zone. So if patient is in this zone, these are ideal candidates where fluid resuscitation can be done, like in hypovolemia, dehydration, or hemorrhage. And another is the flat portion, that is a plateau zone. This is preload independent zone, and extra IV fluid do not significantly improve stroke volume, like in cases of heart failure, fluid overload, or cardiogenic shocks. So in this case, what we are going to do is, suppose if the patient is not showing any signs of fluid overload, then we can try with infusing fluids. But if it is there, then we can try to increase the contractility by vasopressors or decrease afterload by using the diuretics. Now, assessment of this fluid responsiveness is by static markers and dynamic markers. I think Dr. Shambhavi will be discussing in detail about these. Now, this is a concept about stressed volume and unstressed volume, and its relevance to critical care practitioners. So usually what happens in emergency medicine or in critical care, even in anesthesia, the fluid resuscitation is focused on the function of the left ventricle and venous return. So what are the factors? The factors influencing venous return physiology are right atrial pressure, mean systemic pressure, and the vascular resistance. So what is basically this mean systemic pressure? It is the driving pressure. It is basically the driving pressure which competing against the right atrial pressure to create a gradient that promotes the forward flow if all blood flow were to cease. So in reality, what happens is it takes a certain volume of fluid to fill the vascular bed to the point where its presence exerts force on the vessel wall. So the minimal amount of fluid that is not exerting a force is the unstressed volume, and any volume above this level is the stressed volume. So the increase in the stress volume, the increase in the mean systemic pressure, and hence increase in the venous return. I will try to explain this stressed and unstressed volume. I will try to simplify this by, let's imagine a bathtub representing a venous vasculature with a drain pipe connected to one side which drains to a bucket representing a right atrium. So this is the bathtub, this is drain pipe, and this is your bucket, which represents the right atrium. So the flow is determined by the relative pressure between the tub, that is the PMS, the bucket, the right atrial pressure, as well as the length and diameter of the drain pipe. This is the venous resistance. So in this model, the tub will drain to the level of the drain pipe, but no further. So it will drain up till here. It will not drain more than that. And for this remaining water or blood, that is unstressed volume, to flow to the bucket to maintain a forward flow, what we need to do is either we can increase the volume or we add vasopressors, which will compress these vessels. However, this will decrease the system compliance, shifting a portion of the unstressed volume into the stressed volume, which will allow more water to drain from the bed without adding additional volume of the system. So basically, we need to understand this concept. I think I have some time, so I will discuss this with some examples. For example, in a patient with septic shock, hypotension is observed is typically a distributive process. Vascular bed has vasodilated, causing a relative hypovolemia, though volume is unchanged. The volume is same, but because of vasodilation, the hypotension is there. And there is a shift of portion of the stressed volume to the unstressed state, leading to a decrease in PMS and in turn the venous return. To overcome this, either you have to add volume or add vasopressors to the venoconstrict and shift unstressed volume to the stressed one. So if patient is showing signs of overload, go with vasopressor, and if not, then fluid boluses should be given. Now, in another example of hemorrhagic shock, initially body compensate by catecholamines release, leading to vasoconstriction and shifting unstressed volume to the stressed one to maintain the PMS temporarily. But if bleeding continues, the replacement of the lost blood with the blood products is an attempt to restore both the total volume and the stressed volume to a more physiological state. Now, in anesthesia also, a certain degree of hypervolemia is necessary to maintain organ perfusion during anesthesia and surgery. However, fluid given after induction of anesthesia mainly increases unstressed blood volume because vasodilation occurs as a consequence of anesthesia. Since the patient is euvolumic, so the stressed volume has now become the unstressed one. So at this point of time, additional fluid administration is needed to optimize stroke volume, that is to add to the stressed intravascular volumes. Many clinicians still consider this weight approach as gold standard in anesthesia practices. These concepts help, especially the emergency physicians, where patient gets present in shock regardless of the initial volume status. As a result, many patients who may not be truly hypovolemic receive larger volume fluid resuscitation. So this also says that early use of low dose vasopressors, usually norepinephrine in a dose of 5 microgram per minute, will result in venoconstrictive effect, decreasing venous compliance and shifting fluids from the unstressed venous bed to the stressed one. Unless there is evidence of significant hypovolemia, administration of fluids should generally be limited to 20 to 30 ml per kg body weight before starting any vasopressors. So to conclude with, the take-home message from my lecture is hypotonic, isotonic, and hypertonic fluids behave differently, as I have already discussed in the slides on their administration, and revised Starling theory in view of intravascular glycocalyx has a prime importance in movement of fluids in between ECF and ICF. strong iron difference can guide the type of fluid to be administered in specific conditions based on the strong iron difference of the fluids. The concept of stressed and unstressed volume is important to initiate the fluid therapy. With this, I want to conclude my lecture. So thank you.
Thank you. Thank you, Dr. Mukesh, for that excellent overview of the physiology. You covered important aspects, how to differentiate crystalloids, colloids, what is SID, role of SID, IV fluids of choice, etc. And also you mentioned about glycocalyx, very well done. So may I request you to introduce the next speaker, Dr. Payal?
Yes, sir. Yes,
and
sir.
I request the speakers to maintain time of 14 minutes each, if you don't mind.
Sure, sir. So I would like to invite Dr. Payal Jain. Currently, he is professor here, as I already told, in our institute, and she has n number of publications to her name, many book chapters, and she has been organizing and many conferences. As of now, a number of conferences she has organized, and she has been a part of many conferences. So I would like to invite Dr. Payal. Please start your lecture.
Thank you so much, sir. A very good evening to everyone. Perioperative fluid management has actually become a very integral part of perioperative care these days. But before I start with the discussion, we have a therapeutic conflict here. It is a situation where each of the possible decision carries some potential problems. And that is what makes fluid challenge a very big challenge in anesthetized and critically ill patients. It is way back, it was in 1924 that Rudolf Matas first proposed the administration of IV fluids. Over the years, we have become much consistent and conformative to the fluid management. But as knowledge is growing, we have come to know that intravenous fluid no longer remains intravenously. That is why the best method to improve hydration is actually, whenever applicable, by increasing the per oral intake. The scenarios have actually changed these days. The perioperative fluid has become a key element of the ERAs. It has become individualized, that is patient specific, depending upon the risk stratification. It has become condition specific, depending upon the surgery, and no predetermined calculations are used any longer. What we have to maintain is a very delicate balance between hypo and hypervolemia. What is the target of IV fluids? Preoperatively, we have to maintain a well-hydrated and a central euvolumic state patient. Intra-op, restore the effective tissue perfusion, oxygenation, and electrolyte balance. And post-operatively, the weight gain should be less than 2 kgs. Does idle fluid exist? The answer is no, because an idle fluid is something which is not going to change the pH at a constant PCO2. Talking about the novel fluids that we use, the NS is acidotic, the plasma light is alkalotic, the RL that we use is hypotomic, and the stirofentin has more than physiologically required chlorides. Talking about crystalloid versus crystalloids, N number studies have actually shown that 0.9% normal saline is no longer recommended as it leads to increase in morbidity. The only indication of use of normal saline is hypochloremic hypovolemias or traumatic brain injuries. Hypotonic fluids also are no longer recommended. The only recommendation is of balanced salt solution in the whole perioperative period. Talking about crystalloid versus colloid, fluid of choice, non-debatable, it is the crystalloid as the first line of agent. But previously, because of the use of unbalanced and high molecular colloids, the colloids were not incorporated in the fluid management. But with the years and the advancements, now it has been concluded that balanced, low molecular weight colloids like 6% hydroxyethyl starch, 130 by 0.4 are not associated with increased incidence of AKI, RRT, coagulopathies, or mortalities. These days, the equivalence ratio of crystalloid to colloid is 1:1.3. Regular use of albumin in surgical patients is no longer recommended, not even in neurosurgery and not even as a priming fluid in cardiopulmonary bypass. Per se, the dictum is that if you are using hydroxyethyl stat as a fluid, please do not surpass the recommended dose, and its use should be restricted to non-septic patients with no pre-existing renal failure. Now, when to use actually the colloid or start the colloid? It depends. For example, if the patient is hypotensive, then check the fluid responsiveness. If the patient is fluid responsive, then check for renal insufficiency and sepsis. If the patient is not fluid responsive, go for vasopressors. But if the patient is fluid responsive and the renal profile is fine, the patient is non-septic, you can easily go for colloids. But if vice versa, then you have to switch over to the crystalloids. The factors which affect the perioperative fluid requirements are pre-op, the patient himself, the preoperative losses, the volume status of the patient basically, the comorbidities. And intraoperatively, it is the type of fluid, the duration, the anesthesia-induced vasodilation, myocardial depression, the operative losses, and the neurohormonal stress response. Post-op, we have the postoperative losses. Minimize the fasting period. We actually encourage clear fluids and complex carbohydrate loading 2 hours prior to surgery. Please assess the volume status of the patient. Mechanical bowel preparation is no longer recommended, and even if to be done, use isoosmotic agents. We have something known as physiological turnover in fasting patient, that is certain insensible losses because of the perspiration through airway and skin, and some sensible losses, sweat and diuresis. But what we are concerned about actually is the abnormal losses that are because of fever, gastrointestinal losses, or the hemorrhage. Now, when you're planning a fluid regimen, please beware, exact figure for any surgery is very difficult. When you're prescribing a fluid, beware of the 4 Ds. Fluid is a drug, so specific fluids for different indications. A dose of the fluid can actually make your fluid a poison. Beware of the duration, that is when to start and when to stop, and be prepared to de-escalate the fluid. Now, starting with the resuscitation fluids, it is basically to correct the intravascular volume deficit with adequate perfusion pressure. Now, in a healthy individual, it has been seen that it is not necessary to give any compensatory fluids for the fasting deficit. First. Secondly, no fluid has to be given for the physiological insensible losses. The most common fluid to be used as resuscitation is the balanced salt solution. Never go for glucose as the resuscitation fluid. Preloading that we used to do as a resuscitation is no longer recommended because it leads to release of ANP, which is going to damage your endothelial glycocalyx. And most importantly, what we are always worried about is the anesthesia-induced vasodilation and the hypotension because of our induction agents and the spinal or epidural. And as discussed before, all the fluid that you're going to give actually adds up only to the unstressed volume, and it is not going to help us. The resuscitation fluid is actually required only in the cases when we are dealing with major traumas like hemorrhages or ruptured abdominal aortic aneurysm. For this patient, yes, the fluid balance have to be positive. You have to treat like 30 ml per kg per hour of the fluid or 3 to 4 ml per kg over 10 minutes to see the response. You can add vasopressors or even colloids and reassess the patient before taking to OT. Coming to replacement fluids, these are the fluids which we actually give to correct any developing deficit intraoperatively. And what we have to give is actually mimic the fluid that has been lost, quantity as well as quality. Most common, again, balanced salt solution, but in this case, even colloids and blood products can be used depending upon what you want to replace. But please remember, benefit is from avoidance of excess of fluid, not completely restricting it. Now, what to replace? You have to replace only 2 things. First, the evaporative losses from the wounds. And it has been seen maximum of viscera, even if exteriorized, will lead to 32 grams per hour of fluid loss through evaporation. First. And second that you have to replace is the blood loss. The blood loss can be replaced either ml by ml, that is volume by volume, as said by restricted fluid therapy, or you can go for hemodynamic variables like in goal-directed fluid therapy. And what you don't have to replace anymore are the third space losses, because the entire concept has been abandoned. Now we'll add our maintenance fluids to the replacement fluid. Maintenance fluids is something that we lose because of the physiological processes like diuresis and insensible perspiration. And what you have to add is only 2 to 3 ml per kg per hour. This has to be added because in general anesthesia, we have an inhibition of the autonomic control of the CVS, which leads to a kind of distributive shock, which is very prone for a GI mucosa. And when splanchnic hypoperfusion is there, that leads to increase in 5-HT3 receptors, making the patients very prone to PONV. That is why these maintenance fluids, again, balanced salt solutions, have to be always added. But according to many authors, this fluid is more or less replaced by the different anesthetic dilutes or the antibiotic medications that we are using. So this is the stage that we all have to be very careful about, that aim for a neutral fluid balance, or if required for certain surgeries, we can have a cumulative positive balance of only 1 to 2 liters. Please don't overload the patient at this time. Coming over to the post-operative phase, that is the organ support phase now, we have efficient healing, efficient hemodynamics, efficient tissue perfusion. Avoid a positive net fluid balance because post-operatively already stress is there, so transcapillary leakages is already present. Fluid of choice, again, balanced salt solution. But please remember, earlier the oral, always better it is. When the patient has already started on 25 to 35 ml per kg per day of oral, titrate your IV fluids. In recent studies, it has been shown that some amount of permissive oliguria is actually good, and it is not an indicator of your post-operative renal failure, because in stress, our body releases vasopressin. So 0.3 to 0.5 ml per kg per hour of urine output is sufficient. Please don't treat it rigorously. In the post-operative phase, stabilize the patient. If TEN, TPN has to be used, use it instead of maintenance fluid, not along with them. The target is 0, a slightly negative balance. Especially for the postgraduate students, especially prescribe it, the type of fluid, the rate, the volume, the dose. Correct the electrolyte disorders, and the full regimen should be given for 24 hours. Change has to be done only after a clinical examination, a change in diet, or some change has been there in the lab results. In hemodynamically stable patients who are not able to drink, please cover for the daily requirements of water as well as the electrolytes. De-escalation phase is actually required to remove the extra fluid from the body, which is known as the goal-directed fluid removal or the organ recovery. We have various therapeutic options for it, but the most important thing is we should know when, how, and how much we have to remove. That is, define a clinical endpoint like improvement in oxygenation because of the resolution of your pulmonary edema. Set a fluid balance like 1 liter of negative balance in 24 hours. Set some perfusion and renal safety precautions. For example, if vasopressors are being used, stop it. If the creatinine increases by 25%, you have to stop it. Re-evaluate, adjust. And we don't have to land up our patient in the hyperperfusion state. Now the everlasting dilemma, the fluid strategy that we have to use. We have 3 fluid strategies. The liberal, that is the traditional one, the zero, and the goal-directed fluid strategy. Traditional approach, liberal, is no longer recommended. Coming over to the zero or the restrictive fluid therapy, it covers only the basal fluid requirement of 2 to 3 ml per kg per hour plus the blood loss in the surgery. That is only thing that is covered in zero fluid therapy. 1:1 ratio. The problem is occult hypovolemia, but this is very helpful in certain cases like thoracic surgeries. The weight gain has to be less than 1 kg. The only thing we have to be cautious about it, that in certain trials it has been seen that restricted fluid therapy leads to increase in the incidence of acute kidney injury. So zero fluid therapy has to be done only in mild to moderate risk patients. If we have a major surgery, then those surgeries where the blood loss is less than 1 liter, only in those surgeries we use zero balanced fluid therapy. It is quite cost effective because the monitors that are required are all the basic ASA monitors. For example, the blood pressure monitoring, NIBP, but it has significant limitations. For example, if you're using RFT and the patient becomes hypovolemic, what our body does for homeostasis is that it maintains the pressure at the expense of flow. But the organ needs perfusion as well as the flow. The goal-directed fluid therapy is a protocol-driven treatment with specific hemodynamic endpoints. Like it has a target population of high-risk population, timing of intervention has to be too early. It has various types of interventions like imetrof, vasopressors. It has target variables that we have to check with target values. These are the sum values of the goal-directed fluid therapy. Now, the problem and the right question, the real question is limiting the amount of fluid given to the adults during surgery is equivalent to using hemodynamic monitoring, which continuously changes the blood pressure or the speed of blood flow? There has been unnumberable studies comparing the goal-directed fluid therapy with the restricted fluid therapy. And believe it or not, ironically, even the latest optimized 2 has said, yes, they both are actually similar in the perioperative outcomes, especially the morbidity and the mortality after 90 days. So it is said that overall beneficial outcome to goal-directed fluid therapy appears to be related to patient risk stratification, and it should be done only in groups with higher mortality rates and more comorbidities. Now, perioperative fluid without monitoring is not possible. In low risk patients, low surgical risk, use only basic monitors. Whereas, as the risk increases, you have to use basic plus advanced monitoring techniques. Some things before conclusion you have to know is, in anesthetized patient, the elimination half-life of crystalloid actually increases several hundred minutes, because of which that de-exhalation phase becomes very important for us. Parameters like MAP, HR, diuresis are not related only to the circulatory system. There are many other factors which actually confound them. Interstitial edema that are caused is not because of fluid excess. It is because of the salt excess, and it actually takes time to excrete. Fluid overload is actually invisible. Stopping triggers of the fluid are still ill-defined. And mild positive fluid balance is actually helpful to reduce the PONV. And we all have to be aware of that fluid creep, which is the quantitative relevance of the fluids administered as diluents and to guarantee the catheter patency. Finally, I conclude that the fluid therapy should be individualized, always follow the 4 Ds, assess the patient first, check the indication, prescribe properly, reassess, manage. And please be calm, patient, and vigilant when dealing with the fluids. Thank you.
Thank you, Dr. Payal. That was excellent overview of the perioperative fluid management. Very well done. You have said
you.
several important statements like that fluid should be individualized. Low molecular weight hydroxyethyl starch is not associated with AKI. Regular use of albumin is not to be encouraged. There is no ideal fluid. Minimizing fast period. Plan the fluid regimen, and the optimization, stabilization, de-escalation, etc. So many important points were covered in a short period. Thank you so much. I now request Dr. Mukesh to introduce the third speaker of the day.
Thank you, sir. Now, my next speaker is Dr. Shambhavi Chauhan. She is MD Anesthesiology and DM in critical care. She is currently looking after 40-bedded ICU in our institute, and she has many achievements to our caller. That is our Young Talent Hunt Award, Critical Care 2020, GK Sinha Young Research Award, presented papers in so many, and 4 publications till now, and written 2 book chapters. Now, I will ask Dr. Shambhavi to please start your presentation.
Very good evening, everyone. Thank you, Mukesh sir. Thank you, ICA, for the opportunity. I'll be telling about fluid therapy in ICU. It's a very vast topic. I'll try to go through the broader concepts of fluid therapy in ICU in very short. I have no financial disclosure or conflicts of interest regarding the presentation. These are the contents of my presentation. Now, the first question we should ask is why to give fluids? The physiological rationale for resuscitation is to restore the intravascular volume, thereby increasing preload, cardiac output, augmenting oxygen delivery, and improving the tissue oxygenation. Now, whom to give fluids? Even if you give 500 ml of fluid bolus to a healthy, normal individual, the cardiac output, the cardiac index will increase. But that doesn't mean the individual needs fluid. So I'll give you 2 examples. There's one patient who has come with the BP less than 90/60, but the patient is conscious, obeying, following commands completely, and there are no signs of tissue hyperperfusion, lactates normal, capillary refill time normal, no oliguria. And there's another patient, for example, 73-year-old female with the background of diabetes, hypertension, and she underwent total hip replacement 6 days back. Now she has developed oliguria and altered mentation, and her BP is 130/100. So I believe everybody would agree the second patient, this patient is an acute circulatory failure. So it is very important to understand the difference between shock and hypotension. Shock is not merely the presence of hypertension, but it is the inadequate tissue perfusion whenever there is an imbalance between oxygen supply and demand. The pitfalls of hypertension can be without shock, and shock can be with the normal blood pressure. As we are very well aware of the cerebral autoregulatory curve, and we can see in patients with chronic hypertension, the curve shifts towards the right. So these individuals are predisposed to hyperperfusion whenever they are exposed to lower than their normal blood pressures. Now, when to give fluids? Fluids are the first line therapy for resuscitation in shock. Any patient coming with hemorrhagic shock, obvious hypovolemia, we have to resuscitate the patient. Nobody expects us to check for any responsiveness, check any variable, dynamic, static, check for responsiveness. Obvious hypovolemia, obvious hemorrhagic shock, we have to resuscitate. Similarly, in the distributive shock, as in sepsis, there is relative hypovolemia because of increased venous capacitance. We have to resuscitate the patient. It has been substantiated by the prominent guidelines as well, surviving sepsis guidelines. Most recent one, 2021, it recommends 30 ml per kg of fluid in the initial 3 hours. And advanced trauma life support, 10th edition, it recommends 1 liter of fluid bolus, and along with blood products, obviously, if the patient is coming grade 3-4 hemorrhagic shock. Now, whenever we are not sure what kind of shock we are dealing with, and when the patient has received fluids, then the concept of responsiveness comes. So I'll add on to the scenario of our previous patient. Suppose this patient has already received 1500 ml of crystalloids in ward since morning, and by the afternoon her shock was still worsening. She was shifted to ICU. So now, do you want to give her more fluids? So now comes the question of responsiveness. Responsiveness is the whole purpose of responsiveness is to identify those patients in which after administering fluid, there is increase in the stroke volume. That is to identify the patients who lie on the steep part of the Frank Starling curve. Now, how to check responsiveness? There are 2 kind of indicators. One is static, one is dynamic. Static indicators are basically the measure of preload. They do not measure responsiveness. They just get some idea about the preload. These are central venous pressure, pulmonary artery occlusion pressure, LV end diastolic pressure, LV end diastolic area, and IVC diameter. I won't go in much detail about them because they are less sensitive, less specific, and also therefore they're less useful. And also these guidelines, surviving sepsis guidelines and ESICM task force, they also recommend to use dynamic variables over the static to predict fluid responsiveness whenever available. But a few slides about CVP, because it is most commonly used marker for fluid responsiveness in the resource limited settings. So in this graph, I'm showing the relation between end diastolic pressure and end diastolic volume. The graph 1 shows a patient with normal RV compliance, and in graph 2, a patient with reduced RV compliance. So in graph 1, we can see with the same value of CVP, same 8 mmHg of CVP, the patient with normal RV compliance has higher end diastolic volume as compared to the patient with low RV compliance. So we can infer that a single reading of CVP cannot tell us the value of preload or the end diastolic volume. Whereas if we see the change in CVP in response to fluid, it may be a better marker. Because we don't know about the RV compliance, and RV compliance keeps on changing in same patients at different times. So if we assess the response to fluid, suppose we have given certain amount of fluid in this patient and there is very minimal change in CVP, we can say, okay, probably the patient has low end diastolic volume, hence low preload. If the change in CVP is excessive, then probably we can say the patient has higher end diastolic volume. So as a rule of thumb, change in CVP measured before and after 5 minutes of fluid bolus, if it is 0 to 3, the system is underfilled, 3 to 5 adequately filled, or 5 to 7 mmHg is overfilled. Obviously, there are certain problems with all the static indicators which we have to keep in mind. Now coming to the dynamic indicators. Dynamic indicators are these indicators, they induce a change in preload, then they assess its effect. So they depend upon the heart-lung interactions during mechanical ventilation. During inspiration, there is decrease in the venous return to the right side of heart and increase after load. And after 3 to 5 heartbeats, there is increase in venous return to the left side of heart because of squeezing of pulmonary blood into the left atrium. And then there is decrease in the afterload. This variation we can see in the arterial pressure in the form of swing or variation in the waveform with the airway pressure. We can assess dynamic indicators. Most commonly used is the pulse pressure variation, because we just need a single arterial line for this, and the cutoff for PPV is 13%. Second is stroke volume variation. We need a cardiac output monitoring. The cutoff for this is 10%. And if we don't have a cardiac output monitoring or arterial line, we can use ultrasound, and we can measure IVC diameter in M mode. We can compare the diameter in inspiration and expiration. And if there is more than 50% collapsibility in spontaneously breathing patients, or 12 to 18% variability in mechanically ventilated patients, then we can say the patient is fluid responsive. Again, the problems with the SVV and PPV, there are certain prerequisites which we need to keep in mind before assessing SVV or PPV. Now, how to give fluids? We can give a fluid challenge, or there are alternatives to fluid challenge like passive leg raising test and expiratory occlusion test, or there is something called tidal volume challenge. So how to give fluid challenge? Fluid challenge is a fluid bolus given at a defined quantity and rate to assess the fluid responsiveness. So what volume and rate should be used? Usually in clinical practice, we give 500 ml of fluid over 10 to 15 minutes, but it has been postulated that minimum 4 ml per kg of fluid should be given over 5 to 10 minutes. There's something called mini fluid challenges also there, where we can give 100 ml of fluid in 1 minute. It has been proposed in the operating room where the patient status can change very quickly. Now, after giving fluid challenge, we have to continue our assessment of the response to the fluid. We can assess clinically or by static or dynamic parameters. Now, this is a very lucid schematic presentation by Jain, Vincent. If we give fluid challenge of 200 ml over 10 minutes and filling pressures increase excessively, we have to stop the fluid challenge, because irrespective of if the cardiac output increase or not, if filling pressure increase excessively. If filling pressure increase reasonably, we'll continue giving fluid challenge until there is a response or until our target is reached. If a cardiac output does not increase and also filling pressure do not increase, then we'll have to think if we are giving enough fluid or there are concurrent losses. Now, alternative to fluid challenge is the passive leg raising test. It transfers around 300 ml of venous blood from legs and abdomen, and it mimics the fluid challenge by increasing the preload. Advantages over giving normally we give fluid. The advantages of PLR are there is no exogenous fluid administration. Therefore, we can repeat it, and it is good for patients with poor or dilated LV. It is reliable with spontaneously breathing patients as well, and no problems with arrhythmia. But we need continuous cardiac output monitoring, either invasive or non-invasive via echo. We can measure VTI, bioimpedance, or aortic blood flow. But then again, the person has to be very, very skilled in echocardiography to pick up the changes very fast. Now, there are problems with PLR as well, very short-term and transient changes. The bed has to be like that to perform the PLR. We cannot just lift the patient legs, and it is not useful in patients with intra-abdominal hypertension. Now, which fluids to give? There are n number of studies, again, comparing balanced crystalloid versus 0.9% saline, comparing colloids versus crystalloids. But very recently, ESICM has published guidelines in 2024, part 1, which says balanced crystalloids are to be preferred over isotonic saline, and crystalloids are to be preferred over albumin in general critically ill patients and in sepsis. Isotonic saline are to be preferred over balanced crystalloids and also over albumin in traumatic brain injury. Albumin can be preferred over crystalloids in cirrhosis, but with very low certainty of evidence. And isotonic crystalloids over small volume hypertonic crystalloids in critically ill patients in general. It also has a very low certainty of evidence. Now, fluid is, it's not it is harmful actually if we give more fluid. So we should know overzealous fluids, they are harmful. They increase mortality, they increase ICU length of stay, and also hospital length of stay. So we should know when to stop. We give fluid challenge and we'll continue our assessment if there is reversal of the defect that has prompted the fluid challenge in the first place. So we can see all these clinical variables like hypertension, tachycardia, oliguria, altered sensorium, lactates, we can see. And we should continue our assessment by dynamic and static variables. If there is no hemodynamic improvement, we should stop the fluid challenge. These are the therapeutic endpoints. And very importantly, we should keep in mind about the these safety endpoints. We can monitor for fluid overload clinically if we can check if the respiratory rate is increasing, whether there is appearance of PREPs or oxygenation or compliance is worsening. We can monitor by using lung ultrasound the appearance of B-line. There are certain protocol, false protocol is fluid administration limited by lung sonography, the VEX score, and we can measure extravascular lung water. Fluid has to be treated like an antibiotic, and definitely it needs stewardship, explained before. 4 phases of fluid therapy has been also explained before. I would just like to stress that we should ignore the fluid balance in first 24 hours during resuscitation and optimization phase. But once the patient has been stabilized, we have to be very mindful about the global increased permeability syndrome and begin re-resuscitation after a few days to weeks. Now, before ending my presentation, I would like to emphasize upon the common misconceptions. First is give fluids to increase CVP to 12 mmHg to exclude underlying hypovolemia, and fluid should be withheld because the CVP is high. Now, we have already understood that a single reading of CVP is not reliable. It does not give any idea about responsiveness. Fluid challenges should not be tried in patient with poor cardiac function or should be withheld because patient has already received a large volume in a short time interval, or there is cumulative positive, patient is cumulatively positive during the initial phase of resuscitation. No, we can assess fluid responsiveness, then decide upon whether to give fluid or not. Then fluids during resuscitation can be managed as standing orders to nurses. No, we have to be at the bedside, we have to assess response and then decide upon further fluid order. And lastly, colloids are better. There is no role of hydroxyethyl starches in ICU, rather they are harmful. And for albumin also, there are very specific, very few indications. To summarize, whenever we have a patient with hypotension, we have to ask three questions. One, whether the patient is in acute circulatory failure. If yes, whether the patient is fluid responsive. And then if there is any major risk in giving the fluid. If there is no major risk, we can continue with the fluid challenges and continue reassessment clinically or with static or dynamic parameters until there is improvement and resolution or our safety limit has reached. If there is any major risk, then we can think of adding other vasopressors or inotropic drugs, or we can consider advanced hemodynamic monitoring. These are my references. I would like to end my presentation with this quote: not everything that can be counted counts, and not everything that counts can be counted. We must understand that fluid is not a sacrosanct. We have to rely on our clinical knowledge and integrate with these monitoring techniques. It is very crucial for us to know how to give fluids to the critically ill patients, and most importantly, when to stop. Thank you.
Thank you, Dr. Shambhavi, for that excellent talk on fluids in ICU. Very well done again. You mentioned
Thank
about
you, sir.
focus, responsiveness, and when to stop fluids and what are the misconceptions. Very well done. Please stay back till the end because there may be some questions addressed to you. Now I request Dr. Mukesh to introduce the last speaker of the day, and then we'll continue with the discussion.
Thank you, sir. So our last speaker is Dr. Vinamra Tiwari. He is currently working as consultant in charge in the emergency department in our hospital. He has been invited faculty in many workshops and conferences. And to add to it, he has cracked FRCA MCQs, and soon he will leaving India for UK. And he has 4 publications in reputed national journals, and he has keen interest in fit and focus. So over to you, Dr. Vinamra.
Thank you for the introduction, sir. Good evening to all the members. I'll be swiftly shifting to the slides. So first I'll be discussing the trials, and then I'll be going over the recent advances. So the trials, there is no disclosure. I'll be changing the slide first. So it is stuck. It is stuck, actually.
Then you might have to unshare and reshare again.
Yes, sir, I'll do it. So should I present in this mode only so that?
I leave it to you if the screen mode is not possible.
Okay. So I'll be going through the slides now, sir, because it is not possible on my end now. So the trial I'll be discussing will be the SPIT trial. And in this, a comparison was made in between the plasma-led and the normal saline, which was administered to more than 2,000 patients in multiple ICUs in New Zealand. And the outcome was compared as an impact on an AKI. So no net benefit was shown by the plasma-led over NS. The second was the SMART trial. Here an impact over AKI and mortality was assessed at a single academic medical center in the US, where the comparative study involved more than 15,000 adult patients, and the comparison was made between the balanced salt solution and the normal saline. Mortality was lower in the balanced salt solution group. Third will be the BASICS trial. There were 2 objectives in this trial. First was to compare the plasma light with the NS, and the second was to compare the impact of mortality and the kidney injury in more than 11,000 ICU patients when infused at slower rates, that is 333 ml per hour, and faster rates, that is 999 ml per hour. So in this, no significant difference in 90-day mortality between the plasma light and saline was observed. No difference in AKI or need for RRT between the groups, and infusion speed also had no impact on mortality or AKI. Next will be the classic trial. Here across 8 European ICUs and in more than 1,500 patients, a comparison was made between the restricted fluid strategy, that is minimizing fluid plus early use of vasopressors, and liberal fluid strategy in septic shock patients. And here again also no difference was found, like not significant mortality between the two groups, though fewer patients who were in the liberal group required RRT. So this is the summary of the trials, but I'll emphasize upon the 3 points, that is balanced crystalloids are generally safer than saline, but not always superior. Fluid restriction in septic shock does not necessarily improve the outcome. And finally, the most important point, fluid management should be individualized based on the patient conditions and the clinical judgment. So now I'll be moving towards the recent advances in monitoring. These will be the topics of my discussion. First, I'll be discussing bioreactance. So the bioreactance, it is a non-invasive method for measuring cardiac output that analyzes the phase shifts of the electric currents applied across the thorax caused by the blood flow dependent changes to determine the stroke volume and thus cardiac output. So I'll be showing a diagram. So the diagram on the left is an assumption of the thorax wall that has just 2 compartments, that is cellular and an extracellular compartment. And cellular compartment can be seen as B, marked B, and extracellular as A. This simplified assumption has been done to emphasize upon a fact that the cellular membranes will add capacitance and the extracellular spaces will add pure resistive forces. So this article which is on the right is actually showing some values for the capacitance. So they have mentioned that cell membranes have a capacitance of around 1 microfarad per centimeter square. So now further progressing, next slide is showing the placement of the electrodes in the bioreactants. So there are 4 electrodes which are attached as a part of the monitoring. The yellow marked part of the electrodes will generate an AC current, which will flow through the thorax tissue and is represented as a red sinusoidal wave in the graph below. Now a bit of relevant physics here. So when a pure capacitance in the circuit is attached, the voltage lags behind the AC current by 90 degrees. That is, the voltage will follow the current, and that can be appreciated as well in the graph as shown in the blue wave, which is following the red wave. Now there is a theta which is mentioned that is known as phase shift and is related to the capacitance offered. Although not much evident, but there is also a difference in the amplitude. That is because of the resistance, which is due to the extracellular compartments. So now the inner part of the electrodes that is also marked as green in the second diagram are going to pick up the voltage wave and it will traverse back into the receiving module. So the information received is analyzed to calculate the cardiac output. So why bioreactance is superior? Because of those 2 facts which I have said earlier, that better amplitude and phase shift differences leads to good signal to noise ratio. And these devices are less prone to artifacts and therefore it has improved accuracy as compared to bioimpedance. Then I'll be moving towards the plethysmography variability index. It is also a non-invasive dynamic parameter used to assess fluid responsiveness in mechanically ventilated patients. It is derived from pulse oximeter waveform and reflects the respiratory induced changes in the perfusion. It was beautifully described by Dr. Shambhavi in the previous lecture. So as we can see that PI max and PI minimum are there, and PVI is used to calculate from these 2 parameters. Once the PVI is achieved, if it is more than 14%, then it will be the fluid responsive state, otherwise it is not. The disadvantage are actually related to the lower perfusion states and as well as it is influenced by arrhythmias. Now transthoracic echo, I'll not be going into the details, but yes, there are 4 parameters which can guide us up to the hypovolemia state. In left ventricle, if left ventricular end-diastolic area is less than 10 centimeters square, in left ventricular end-diastolic distance is less than 4 centimeter. If during contraction of left ventricle kissing papillary sign is being evident, and in the LVOT VTI, if it is less than 13 centimeter, which also improves on passive leg raising, these are consistent with the findings of hypovolemia. In the right ventricle, apical 4-chamber view can give us a smaller ventricle, which can give us a hint about it. and IVC collapsibility if the D max is less than 1.5 centimeter and collapsibility index is more than 50%. And in the mechanically ventilated patient, if the distensibility is more than 18% and 12% if D mean is considered, it signifies hypovolemia. These are the few diagrams of shots from the TTE diagram. So the diagram which is marked as A is the parasternal short axis view, which is showing papillary muscles getting opposed, which is known as kissing papillary sign. The figure marked as B is showing a M mode view of the parasternal long axis view, which is showing how to calculate the EPSS or MSS. The figure marked as C is again the parasternal short axis view, which is showing us how to calculate the LVEDA, that is left ventricular end-diastolic area. The figure marked as D is the apical 5-chamber view, showing us how to calculate LVOT VTI. Now, transesophageal echocardiography is a bit superior in terms of, because it is a better view and it gives more detailed images in the patients who are critically ill. Moving to the VEXA scan, while the mean arterial pressure and forward flow are important determinants of organ perfusion, other important variables such as presence and severity of venous congestion can also provide the missing information pieces. So it is, I'll just give you a summary of this. So it is screened by looking at the IVC diameter, and it has to be more than 20 mm. So if it is there that 20 mm of IVC is there, then grading is done on the basis of scanning of hepatic vein, portal vein, and intrarenal vessels. So venous flow in the hepatic veins provide the information about the mechanics of the right heart filling pattern, while scanning the flow in the other two will provide the information about the degrees of pressure transmission to the peripheral organs. So in this way, we can grade the condition of the patient. So if the grade 0, there is no congestion, IVC is less than 2 centimeter. If grade 1, the IVC is distended, that is, it is having a diameter more than 2 centimeter plus any abnormal sign, which I'll be explaining later. And in grade 2, there is a moderate congestion where IVC is more than centimeter plus at least one severely abnormal pattern. And in grade 3, severe congestion, IVC more than 2 centimeter plus 2 or more severely abnormal sign. So in hepatic vein, there are 4 ways which can be appreciated. There is a systolic vein, there is a diastolic vein, SD, and there is a atrial and the ventricle, SDAV, which is actually not shown in this diagram. In portal vein, the normal flow of the portal vein is not pulsatile, or a very less pulsatility can be observed. Like it has to be less than 30%. And if it is severe, then the pulsatility will be increasing up to 30 to 50 and then more than 50. In the intrarenal, arterial waves are above the baseline, and the venous is below the baseline. And when the congestion increases, the bifurcation occurs into the S and D waves. And finally, in the severe congested waves, D remains. Then I'll be shifting toward the pulse contour cardiac output. So it combines the pulse contour analysis and transpulmonary thermodilation technique. So if it is useful in hemodynamic monitoring in special conditions like where complex mixed forms of shock are present, like the septic and the cardiogenics are intermixed, and ones where the PAC is contraindicated. So, so to start with, a central line and an arterial line transducer with thermistor tipped arterial picocatheter are 2 important components of the system. Arterial transducer is placed most preferably in the femoral artery. After placing the lines, we can carry the third point, attach the pico via the pressure transducer to the pico monitor. We have to enter the patient details prior calibration. Calibration is done by usually a 15 ml bolus at 8 degrees Celsius through the center line port. Now, pico detects a temperature difference and generates a dissipation curve to which the modified Stewart-Hamilton equation is applied to calculate cardiac output. Now, I'll be showing the dissipation curve. So this is the dissipation curve where the cardiac output is being calculated by the Stewart-Hamilton equation. I have also written that. Now, once the cardiac output is with us, we have to calculate the mean transit time. This is all an algorithm-based approach, so we don't have to do it. Algorithm will do it. So mean transit time is a time interval between the egestion of the cold saline in the CVC to the detection in the arterial line. So the intrathoracic thermal volume, which is a sign of a given volume for a volume of distribution, can be calculated by cardiac output into mean transit time. So now a very good hypothesis is coming in the next slide, Newman hypothesis. So Newman hypothesis is to understand this concept, we have to imagine that there is a series of vessels through which fluid is flowing. The gradient with which the graph is falling, like the dissipation curve is falling, depends upon the volume of the largest container in that series. Now comparing this model with the heart and lung arrangement, which also follows a series placement, that is from the right heart to the lung and then to the left heart. So as anticipated from the above example, the gradient can be used to calculate the pulmonary thermal volume, as lung being the largest vessel in the series. So once we are with the pulmonary thermal volume and ITTVV, we can get the global and diastolic volume by subtracting both. So what is global and diastolic volume? It indicates the preload based on the volume of all the 4 cardiac chambers. So ITBV is the next point. 1.25 times into the global and diastolic volume will give us intrathoracic blood volume. So what is intrathoracic blood volume? Volume of blood in the heart plus blood in the pulmonary vasculature tree. Then moving to the extravascular lung water. Extravascular lung water can be calculated by subtracting intrathoracic blood volume from the intrathoracic thermal volume. It indicates a measure of the permeability of the pulmonary vessels. Now I'll be moving towards the algorithm. So if the cardiac index is less than 3, we have to look for the global and diastolic index. So if it is in less than 700 ml per meter square, then we will be looking for extravascular lung water index. So if it is less than 10 ml per kg, we have to give the volume or fluid, and the target values are written in like below. And if it is less than 700 and the extravascular lung water index is more than 10 ml per kg, we have to be very cautious while we are administering fluid. We have to give inodrops as well in this case. And the other aspect is where the 700, like the global and diastolic index is more than 700, we have to look for the extravascular lung water index. If it is less than 10, we have to use the inodrops. And if it is more than 10, we have to use the inodrop as well as we have to like remove the extra water to follow that guideline, the lower targets which has been set. So I'll be moving towards the next slide now because it is also self-explanatory now. So pros and cons, the advantages are it is less invasive, can stay up to 10 days. Disadvantages are cannot be used with an intra-aortic balloon pulse because pulse wave is actually required for that. And in obese patients, extravascular lung water underestimated as related to the weight of the patient. So use like idle body weight. So the next slide is microcirculatory assessment. So we can assess the microcirculation by first of all directly visualizing the microcirculation. So there are majorly two methods like side stream dark field and incident dark field method, which actually analyzes the superficial microcirculation. This is done in the sublingual microcirculation and it is useful in sepsis, trauma, and cardiac surgery. So the next is contrast enhanced ultrasound, in which microbubble contrast agent is used to evaluate the deeper microcirculation in the cases of renal and hepatic perfusion. But the limitation is that it is operator dependent. Another heading is like functional markers like NIRS, that is near infrared spectroscopy. It is a non-invasive method to measure the tissue oxygenation and it is useful in trauma sepsis. While the sublingual capnometry is also of very grateful use that it measures the carbon dioxide levels in the sublingual mucosa. It detects early stages of shock states and responds to resuscitation. So as the glycocalyx was very beautifully explained by Dr. Mukesh sir, and this is just a like outcome of that glycocalyx is essential for microcirculatory function as well. Syndecan-1, a key structural component, heparan sulfate and hyaluron endocan are most oftenly elevated in sepsis and trauma. So other markers which are of use are angiopoietins, angio1 and angio2. ANG2 elevated
Sir, there is a technical. Just I will share his slides from my screen, sir. Just 1 second. Sir.
But he looks to be static. I think the net is disconnected from his.
Yeah, yes, sir. Yes, sir. 1 second, sir. I'll do that for him.
Can you listen to us?
Just 1 second.
It looks as if the cardiac has suddenly fallen to zero. Vinamra, are you there?
Yes, sir. He is there with me. Just 1 second, and I am sharing his screen.
Yeah.
I am sharing his screen, sir. Just wait.
So your slides are visible now.
Is it Vinamra there?
Hello, sir, I'm here. Actually, there was a technical glitch on our part. I'm sorry for that.
Not to worry, not to worry. Just wherever you left off, you go from there.
Yes, sir.
Slide
33.
number 36 is also.
Yes, sir. Yes.
This was done. This was done.
Okay, sir. Yes, sir. This was a slide which I was on. So other markers, and then after that, biomarkers for fluid overload. There are, sir, a few natriuretic peptides which are anti-pro-BNP and BNP secreted in response to myocardial stretch and volume overload. So MR-pro-BNP, which is mid-regional pro-atrial natriuretic peptide, high levels are associated with cardioembolic stroke and the detection of atrial fibrillation during hospitalization. And as we all know now that the fluid is also associated with an inflammatory state. So fluid overload also raises the CRP markers, and other markers of inflammation are myeloperoxidases, pro-collagen, galactin, and ST2. These are all raised. Other biomarkers like not expected out of it, but CA125, which is a glycoprotein produced from the serosal epithelium, it increases due to the extravascular volume retention and inflammation. CD146 is a marker for endothelial dysfunction, which is increase in fluid overload, particularly in the acute heart failure setting. Urinary biomarkers like MITKINE, IL-6, and GAL hepcidin 25 predict severe fluid overload, especially after cardiac surgery. Adrenomedullin is also a new novel biomarker, which is released as a counteractive response to volume overload. A surrogate marker for this is mid-regional pro-ADM. Now, as we all know that AI is approaching everywhere, so POCUS has been approached by AI. So AI-enhanced POCUS systems are also assisting clinicians these days. So what happens that image recognition, like AI algorithms identify them well and label anatomical structures in real time, reducing the operator dependency. Now, guidance for optimal imaging provide real-time feedback to obtain the best possible views, and automated measurements calculating key echocardiographic parameters such as ejection fraction and cardiac output. The last slide is that the artificial intelligence is also like enrolled in this thing that machine learning models have been developed since recent times. So it predicts hypotension by the model, which is known as hypotension prediction index, predicts intraoperative hypotension from the real-time insights. Nowadays, AI also classifying the patients in characterizing the patient's geometry and classifies the patient into specific endotypes, pattern of hemodynamic behavior. And also continuous non-invasive monitoring are also there these days, where they are utilizing the data from the wearable devices like smartwatches and fitness tracker to provide real-time insights into cardiorespiratory status. Benefits of improved accuracy, reduced cost of expensive hospital visits, remote monitoring, allowing the patient to take a more active role in the life. So these are my references. Thank you for patient hearing and all. Thank you, sir.
Thank you, Dr. Vinamra. Again, very good talk. Very well done. You have started with the trials demonstrating the usefulness of fluid resuscitation. Then you went on to various monitoring modalities, starting with bioimpedance and then plethysmographic variability index, VEXUS, PICO, then the TTE, etc. And also you mentioned about the role of HPI and artificial intelligence. Thank you so much. And if all of you can turn on your videos, we can discuss some questions from the panel, the audience.
Can we see the questions, sir?
But can start if you have add or
No, I can't see it, sir. Chat, please.
go. I think all the probably done most important mentioned which he just said first. Kodandaram on management.
Sir, we can't hear you properly.
That there is some issue with the sound.
We can't hear you.
Yeah, we can hear Kodandaram, sir.
Hear me now?
Better, sir.
I don't
Not
know.
able to hear you.
Yeah, you please. Any questions or any which have to be.
The whole discussion was excellent. All the participants have contributed very nicely to the topic. Starting from the molecular level up to the present context of biomarkers. Each speaker has contributed very nicely to the management of fluid topic. I congratulate all of them for the valuable inputs.
Thank you.
Yes.
Thank you,
I
sir.
think there is a question in the chat box on lactates. Shambhavi, can you clarify him? Lactates, can it be considered in goal-directed therapy in perioperative fluid management? Dr. Muthu Kumar is asking that.
We will ask the ICA. Dr. Shambhavi.
Yes, sir. This is question for me.
Yeah.
So you can, sir, Dr. Payal can elaborate in a better way.
Perioperatively, I'm not very sure.
Sir, I think Dr. Payal is ready to get ready with answer.
Dr. Muthu
Yes,
Kumar
sir,
wants
this
to know
can
whether
be
lactates
used.
can be considered in goal-directed therapy in a perioperative fluid management.
Yes, sir. It can be used as a marker. It can be used as a biomarker in goal-directed fluid therapy.
So I think any one marker we cannot use. We can use like lactates, capillary refill time. In ICU, what we do is this, along with the clinical parameters, like that we manage. We cannot chase only one marker.
Next question from Dr. Muthu Kumar is, many times we see intraoperative during long cases, there is drop in urine output, even on increasing fluid challenges. Can we give small dose of diuretics during this time?
This is intraoperative management.
Yes, sir. Payal, Dr. Payal.
There is nothing like written that whether diuretic should be given when there is oliguria, but oliguria is permissive because of the release of vasopressins. So after when the stress gets released, the urine output will come back. If it is anuria, then we are worried about, but if it is oliguria and the patient is maintaining 0.3 ml per kg per hour, there is no role of giving diuretics. As soon as the stress is relieved, the kidneys will reperfuse itself.
You agree with that? Can you hear me now? No.
Dr. Isha wants to know the dose of dexamethasone in such cases. I don't know what cases she is referring to. Dr. Isha, can you be more clear? She is not mentioned. Dr. Isha, can you be more specific? The dose of dexamethasone in such cases. Till then, I think next, do you use depth of anesthesia monitoring? Somebody is asking.
Actually, it should be used. The depth of anesthesia is related to the hypotension. So we have to maintain the BIS to 40 to 60 because lesser is the depth, more are the chances that the patient will be hypotensive because iatrogenically created by us and the anesthetic drugs. So we have to be careful that the BIS has to be 40 to 60 and we don't lower the depth of anesthesia because that is going to lead to hypotension.
I agree.
And that is not responsive to fluids.
You can't hear me, is it?
We can, sir,
No,
but there is
Voice
some
is
hiss.
breaking.
There is some hiss behind.
I don't know. I'll switch off.
Dr. Kodandaram, sir, there are few more questions there. Can you see that in the chat box?
Yeah.
The last one, CVP guided fluid management.
On guided fluid therapy, can fluid challenge test help in deciding the need for this? Hello.
Yes.
Guided fluid therapy does the fluid challenge test help in deciding the need for this?
We can use fluid challenge test. See, CVP is not obsolete. we can use CVP in if we don't have any other test available. But CVP gives the idea of preload. It doesn't give us the idea whether the patient will respond to fluid or not. For that, we need some dynamic indicators, and then we can give fluid challenge. And then we can decide upon whether to continue fluid challenge or not. But if we don't have any dynamic parameter with us, we can use CVP. There are studies, there are trials which have said CVP in the extreme numbers, like if CVP is less than 6, then like more than 50% of the patient will respond to fluid. And if there is CVP is more than 12, more than 15, most of the patient will not respond to fluid. But it is vague. We cannot be very sure about
Again,
it.
there's a caveat in that, like it depends on the right heart function.
Yes, it depends upon the right heart function.
If there are no questions, I have got few comments to make. So, Dr. Kanchi sir, can I go ahead?
Yeah.
Excellent presentation by Dr. Shambhavi and all of them. Just commonly what we see in our ICUs or casualty are two types of patient. Either they come in hypotension or hypoxia, isn't it? So this is because this is on IV fluids. I think the moment the patient comes to the ICU, you should know how to differentiate the shock, whether it is a hemorrhagic or a cardiogenic or an obstructive or a distributive shock, which is very, very important for your management, whether to use fluids, whether not to use fluids, if at all you have to use fluid, how much fluid to use. That was very well clarified by Dr. Shambhavi. Then she made it very clear that fluid responsive is all about increase in stroke volume, okay, and not in increase in blood pressure or decrease in heart rate, okay. So the evidence, the thing is, if there should be a increase in stroke volume whenever the whether you give a fluid or an vasopressor, so that is fluid responsiveness. Then she also highlighted the importance of dynamic variables over static variables, which was very nice. And ESISM guidelines, they had put 10 questions. Again, one was based on whether isotonic saline should be used or a balanced solution. And she has covered that. And for us to be more clinical, I think there are 4 windows of perfusion. One is a brain, where the patient comes in altered sensorium. Then the skin, where you look at the capillary refill time. The kidney, where you look at the urine output at least 1 to 2 ml per kg. And as somebody asked, lactates can be used. Then use of POCUS. Yeah, POCUS in the ICUs and casualties have made a huge difference in management of patients. But one thing what we have to remember is it is the integration between the echocardiography, the lung ultrasound, and the IVC. Okay, each you have to integrate all the 3 findings to make it. And what is more important, as Dr. Payal told, I think Payal and Dr. Shambhavi also told, it is not a single reading. It is a serial examination which matters, especially in patients with shock. Then as Dr. Vinamra told about VEXUS, so the whole, initially they thought about VEXUS, it starts only after the IVC is more than 2.1, only if it is more than 2.1. But there is a small caveat now, what we look is at the body surface area and then decide on the IVC diameters. Okay, a person whose body surface area is very less, I think you can't expect a IVC diameter of 2.1. And just one thing what Dr. Vinamra told about AI and POCUS, probably there may be presentations, but I would like to differ on that. So if AI has to identify what POCUS is telling, the operator should be very good in getting his images. And a person who is getting good images can always interpret the situation. Right, I think these are the points which I had to highlight.
Thank you. Can you hear me now?
Yes, sir. Yes,
Dr.
sir. We can hear
Sharada,
you.
do you want to say anything? Sharada and Ratan Gupta.
Yes, sir. Thank you very much. I think they were a set of excellent talks. A lot of information I've gained from all of them.
Yes.
Excellent presentations. I just wanted to ask Dr. Payal Jain to elaborate about the hydroxyethyl starch. Which study was she referring to, which said, which promoted the use of HES. That kind of get me more onto board with what's going on with that.
There are a lot
Dr.
of
Payal?
studies which are actually advocated. Should I share the studies with you, or
If you
there are
just
a lot
mention,
of?
it'll be useful at the latest study that has promoted its use, because I haven't found anything online.
Dr. Payal, at least in critical care, when they
No,
refer to
in-
colloids, they refer to albumin, no more to HES.
In critically ill patients, in critical care unit,
Ma'am,
we
in-
don't use hydroxyethyl starch. But in the operating room, we use up to 20 ml per kilo
Sir.
in over 24 hours, and we have not encountered any renal or any other problems in these cases. This it is being published in one of the journals.
Okay, because is that like a routine use, or is that
Ma'am,
in
actually,
a subset of patients?
Actually, first of all, in critically ill patients and a surgical patient, they're both very different in
They're
context
different.
of inflammation and homeostasis.
Absolutely.
So we can't extrapolate any results from the critical care to surgery, to perioperative. And yes, perioperative, there are a lot of studies which actually said that HES is safe. And if you want me to tell you the studies, just give me 1 minute. I'll share the studies with you. There
There
are a
is
lot of
our own
authors.
study. There is our own study being published in off-pump cabbages. Use of hydroxyethyl starch 130 by 0.4 did not lead to any renal dysfunction in patients who were stable.
Is that in cardiac patients, sir?
This is in cardiac patients undergoing off-pump coronary artery bypass grafting. And
Can I
I do
share my
agree with the
screen?
Payal, whatever Payal has said, I totally agree with that statements. It is in critically ill patients where the hemodynamics and other parameters are totally abnormal, then you want to give hydroxyethyl starch. There may be a problem, but in stable patients who need volume status, we did not find any difficulty.
I agree with you, sir, and I agree with Dr. Payal as well that ER is different to ICU. ICU is
Yes.
different.
That is the bottom line.
Yeah, one is resuscitation, one is resuscitation, and one is maintenance.
Yeah.
So they're all complete. I think the physiology applies across the classes of patients, but each patient has to be individualized as when it comes to fluid therapy. I completely agree.
Yes.
But it's just interesting that I heard this 130 by 0.4, and that's a concept because I've been recently only doing critical care and ER. So I wanted to take an anesthetic perspective to this basically. Dr. Payal, I think, has a screen to share.
Yeah, ma'am. I have references there who have actually shown that bleeding risk, etc. But it is in my slides. So if I'm allowed, I can share my screen again.
Yeah, if it can be done quickly, please do so.
Yeah. Here, there are many studies which were conducted in cardiac surgery, even pediatrics, cystectomies, etc., which has actually shown that there is no bleeding risk when we are giving HES versus any crystalloid to be given. These are all the studies which have actually documented that we can easily use HES in cardiac patients also, in cardiac surgeries.
When you say HES, it must be qualified. It is low molecular weight.
It is low molecular weight,
We have to
6%,
qualify that.
130 by 0.4.
Yes. We have to
Yes.
qualify that
Hanji.
statement. Otherwise, it should
Yes.
not be.
Yes, it is
applicable to all
balanced
of them.
solution of
Yes.
low molecular weight hydroxyethyl starch.
Exactly.
So
Thank
what
you.
exactly is the clinical scenario where you would use HES versus a crystalloid?
Are you
Where
asking
See,
me?
colloid, it has a better half-life in intravascularly. We won't use colloid if the patient is septic, at risk of renal failure or inflammation, because these are the scenarios where the endothelial glycocalyx get disrupted, and even a colloid can go into the interstitial places. But for a patient who has an acute bleeding intraoperatively, for example, suppose we are getting a laparotomy done, for example, and there is a lot of bleeding, like placenta accreta, for example, in OPS cases. So we have an acute bleeding. In those cases, we can actually prefer colloids over crystalloids because more the crystalloids we give, more the chances of interstitial edema happening. And colloids remain intravascularly for at least 4 to 6 hours.
Yes, I
Yeah,
agree.
yeah.
Especially if you have an ongoing hemorrhage, you don't really want to use a lot of crystalloids because you're going to dilute and cause more coagulopathy as
There
well.
are more
And
coagulopathies.
acidosis. So I completely agree with you. But I was
So,
just curious as to what endpoints you were looking at. Anyway, to move on, I think that's a very interesting point. Thanks for highlighting that.
and
I
I
would
would like to add other thing, not only low molecular weight, the volume of infusion also should not be excessive. It should be what we thought, we surmised that it should be less than 20 ml per kilo in
Yes.
24 hours.
Okay.
If you
Yeah,
maintain
this is a
that,
recommended dose.
yeah, that much is safe.
I must admit that sir being a cardiac anesthetist, I must point that they love colloids more than the general anesthetists and the intensivists. The cardiac anesthetists are always partial to colloids, and quite understandably so. They want to see quick changes in hemodynamic status. I would also like to mention that there is something called perioperative quality initiative, which also highlights the fact that you should restrict your fasting time to less than 2 hours, and that
Exactly.
decreases the risk of POSD. And there's a lot of I would have loved to screen share. This is an article which has come up in BJ, and which highlights the it's a multi-center study and highlights about 10 or 12 points that can be followed during anesthesia and also critical care. Thank you.
Dr. Payal, these studies which you are talking about, are they extended to 24 hours, 48 hours, or 72 hours? Have they seen the effect of HES in the operating room, or even after they have gone to the post-operative ward?
So they have seen even 90 days post-operative mortality of using HES versus balanced crystalloid solutions.
That's more challenging, isn't it?
I have one question to Dr. Vinamra.
Yes, sir.
Are you Vinamra? Are you there?
Yes, sir.
In one of the places you mentioned LVOT VTA of 13 and less
Yes, sir.
is indicative of hypovolemia.
Yes, sir.
I just wanted to make one comment there. It can also indicate that the LV function is poor.
Yes, sir.
Yeah, that's all.
If it is all combined, then it is more predictive of hypotension.
Yeah, LVOT VTA of less than 13, maybe hypovolemia or maybe
Yes, sir.
decreased LV function.
Yes, sir.
Yeah.
That's what LPOT VPI normally is between 18 and 20 centimeters.
Yeah, it's close
Yes,
to
sir.
20. Yeah.
Yes, sir.
Now, if you see a poor LV function with the poor LVOT VTI, then it is cardiogenic.
Yes, sir.
Okay. If you see a good hyperdynamic LV with a high VTI, then it can be distributive. Okay.
Yes, sir.
Then tachycardia with kissing ventricles, the LV, low LVOT VTI, it is hypovolemic.
Yeah,
Yes, sir.
absolutely. That's right. So, are there any comments or questions? Any further questions? Ratan Gupta, are you there?
Sir, unmute, sir.
Good evening, sir.
Ratan, I would
yeah.
like to hear from
I think
you.
very interesting talks. From the cardiac intensive care perspective, we do see a lot of patients coming with heart failure. And I agree with Dr. Guruprasad, whenever you see a small build patient and you're seeing a IVC of 1.7, but then you should be looking for a VEXUS score as well. We see many times that VEXUS score is grade 3 in a severe PH, right heart failure patient, and the IVC is just 1.6, 1.7 in small bit female patients in our unit.
Yes.
And the other thing which interacts in intensive care is when patients are on multiple diuretics, especially loop diuretics, sometimes the metalazone, they can cause a lot of electrolyte disturbance like hyponatremia. And the other reason for hyponatremia can be dilutional hyponatremia. So trying to correct it with 3% saline might be detrimental in this patient. Probably tolvaptan might be a better choice in these patients to correct the hyponatremia. So I think we always check the BNP levels and assess the heart before starting 3% saline in cardiac unit.
Right.
Dr. Ratan Gupta, I would agree. Actually, a prolonged stay in ICU also results in what ends up with a metabolic alkalotic kind of a picture,
Yes.
which in itself is a mortality indicator. You know, it increases mortality, especially excessive uses of diuretics to de-resuscitate the patient, and the patient ends up with a metabolic alkalotic picture.
And the other thing which we do in our unit is check the weight on a daily basis for the patients. It is a little erratic, but it gives you a rough idea of what's happening with the patient's volume status.
I was little confused about Dr. Payal when she told that intraoperatively you have to give fluids based on the weight of the patient. Is there any way you measure the patient, weigh the patient intraoperatively? I think
Intraoperatively weighing the patient while surgery is going on.
yeah.
You can develop some beds.
Automated beds which shows the weight of the patient.
I have never encountered such bed yet, and have not studied about such beds. Maybe in near future we'll be developing such beds.
Yeah, that's true. That's true. Any final comments from any of the panelists?
Again, on this hepatic vein, portal vein, and intrarenal veins, I think out of the three, now they say the most reliable should be the portal vein.
Yes.
Sure.
And it's quite easy to get also compared to
yes. Portal vein is relatively easy.
vein and renal vein. You have to look at the ECG gating and see which is the
Yes, sir.
systolic and the diastolic. Whereas portal vein, it is very easy. You get just a venous hump and less than 50% and more than 50% of variability will give you the fluid. It's very nice.
Yeah, portal vein is easier to get absolutely correct. I think we are at the end of the session, and it's my duty to thank all the speakers. Dr. Mukesh, very well done about the physiology. Dr. Payal Jain, perioperative fluid management, again, very well done. Dr. Shambhavi spoke about ICU and fluid therapy. Super lecture. Vinamra, again, very well done. Recent advances. Mostly he concentrated on the monitoring bit, but that covered everything. Thank you so much. And I would like to thank my co-moderators, Dr. Kodandaram, Dr. Manjunath, Dr. Guruprasad, Dr. Sharada, for being with us. And we look forward to having you again. And on behalf of the ICA, I'd like to thank all the faculty members and the participants for that excellent show, which has enhanced our understanding of fluid therapy in our patients. Thank you so much, and we look forward to having you once again sometime later.
Thank you, sir.
Thanks a lot,
Thank you,
sir.
sir.
Thank you, sir.
Very much. Thanks, sir. Good night.
Good night.
Good night, sir.
Thank you so much, everyone. So ClearNet is really glad to have all these brilliant people together in this session. So with all your permission, I'm closing the session over here.
Thank you. Good night.
Thank you so much, sir.